excited to present Dr. Banerjee today, who will be sharing his experience and research around dexamethasone. We chose today's topic because dexamethasone can be such a hard part of the multiple myeloma treatment regimen, with side effects that, as Dr. Banerjee will explain, could be lasting. He's got some really exciting new research about dexamethasone dose intensity in newly diagnosed multiple myeloma patients. I've had the pleasure of hearing Dr. Banerjee live as he shares his passion around helping patients thrive throughout their multiple myeloma journeys. I'd like to go ahead and introduce him. Dr. Banerjee is a physician researcher who specializes in multiple myeloma. He has a particular interest in dexamethasone, which we will hear about today, and cellular immunotherapy such as CAR-T. He's a member of the International Myeloma Working Group and has published over 70 peer-reviewed publications with an emphasis on improving the experiences of patients as they undergo treatment for multiple myeloma. And with that, I will turn the time over to Dr. Banerjee.
Wonderful. Thank you, Cindy, for that very kind introduction, and to the HealthTree Foundation for inviting me to speak here. To those patients, maybe for my own patients are here, good to see you again. For those whom I haven't met, it's grateful to have the opportunity to talk to you about dexamethasone. So let's see, the hardest part is always this part, but I think we are in gear. This looks okay?
Looks great, thank you.
Wonderful. So I made my talk a little bit more provocatively titled. Some of you who know Jenny Elstrom will know that she actually wrote a song about dexamethasone called Dex the Devil or something similar to that. So I'll be speaking about Dex the Devil, reasons to consider dexamethasone dose reductions in multiple myeloma. Here are my disclosures. It's worth noting that in general, I try to use generic names whenever I talk with physicians, but obviously because it's a patient-centered talk, I will use brand names. I'll try to remember to use them. If I forget and you wonder what drug is he talking about, ask and I'll remind you. But obviously, if I use a brand name, it's purely for this audience. It's not no endorsements are intended. And so those of you who have heard this talk or an early version of this talk when I first started down this road of dexamethasone research 2 years ago may remember this slide that I put up then from one of the Batman movies, the Dark Knight movie. And this is how I view dexamethasone in myeloma on multiple fronts. It's a quote by Harvey Dent saying, "You either die a hero or you live long enough to see yourself become the villain." The idea here is that dexamethasone, we'll talk about, does have some very short-term benefits and but long-term kind of detriments. And on the flip side, dexamethasone 30 years ago used to be the only drug in our arsenal. It was the hero of treatment then. Now, not so much. So first, in terms of what are corticosteroids, so dexamethasone is a type of corticosteroid or a steroid medication. So at a very simple level, these are what steroids are, right? What they are not are, Barry Bonds growth, muscle kind of anabolic steroids. They're different kinds of steroids. These are hormones that are made by our adrenal glands to help with, what I call a fight or flight response, which many of you have heard some version of that before. So fight or flight response and regulate blood sugar. So they often help to, raise people's blood pressure, cause them to feel more anxious. But these are all expected side effects of any corticosteroids. They also regulate blood sugar. In particular, they counter-oppose insulin. So insulin brings blood sugars high, brings low, I'm sorry. Steroids bring blood sugars high. There are many examples here. Hydrocortisone, many of you are very familiar with, over-the-counter. That is a steroid, often given topically, meaning on the skin. But there are other examples like prednisone, methylprednisolone, which is solumedrol, and of course, our friend and villain, dexamethasone. So dexamethasone is almost as old as me. I am older than this paper in 1989, but honestly, not by very much. So many of you may have been alive in this era, or some of you may have been treated initially in this era. So this was, one of the first studies showing that dexamethasone had some benefit in multiple myeloma. They dosed it even back here, if you notice, 4 days on and then 4 days off, basically. Here was dosed in milligrams per meter squared, which is complicated, but approximately around 40 milligrams weekly. 40 milligrams per dose, showing some sort of a benefit. This was, again, in the 80s. In the 90s and leading into 2006, this publication was a study of, it was called the IFM 9501 study. So it was a French study of what they called older adults. Again, older in France, Europeans view anything over 65 as old. In America, we view patients like that as the median, right? Average for patients with multiple myeloma. So they were called old there. I wouldn't call them old. They were randomized to receive either dexamethasone-based induction, so 40 milligrams daily for 4-day pulses. So what that means is not what we typically do nowadays, 40 milligrams for 4 days, daily, 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 and then stop for 4 days, and then start for 4 days, and stop for 4 days, right? So it's basically pulses, 4 days in a row of dexamethasone, then 4 days off, then 4 days on, etc. Versus another regimen called melphalan prednisone. Some of you may remember melphalan. That's the drug in transplant, IV. This is oral melphalan as a pill. And so, interestingly here, and maybe not surprisingly, they actually found that the patients who got this hydrodexamethasone did more poorly. And in fact, many of them actually passed away, primarily due to infections or blood clots, etc. And the trial was actually closed early by their monitoring board. The committee they have to assure patient safety closed the study early when they saw these initial results. And this study actually, the results here in Blood, published over almost 20 years ago, said that dexamethasone should not be routinely recommended as first-line treatment in elderly patients with myeloma. Again, a lot of words there I would take some objection to or add some nuance to, as we'll talk about. But I think that that was the beginning of the knowledge that perhaps dexamethasone 40 milligram pulses, so 4 days in a row, is not the way to go. We then went to a randomized study that was quite helpful. So this was the ECOG E4A03 trial of RD induction, so lenalidomide plus dexamethasone. In the US, most patients diagnosed in the last 5 years will not just receive RD, they'll receive VRD with bortezomib Velcade or something along those lines. This is just RD, Revlimid, Dex, all oral. The Revlimid 25 milligrams throughout for both arms. Half the patients got dexamethasone in pulses, and half got Dex 40 milligrams once weekly. This was a fantastic trial, in large part because it was patient advocates like many of you listening to this who were the ones who really pushed for it. There was one, I never had the privilege of meeting him, but his name was Mike Katz, but he was a patient advocate living with myeloma, really pushed to make this trial happen, and it's because of him that this trial happened. And you can see here that the group that got the high dose dexamethasone, 40 milligram pulses, again, 4 days on, 4 days off, did technically have lower reduction, like the reductions lowered more of the AMP spike, right? So the odds of having a response were higher. However, overall survival was worse. Again, these patients passed away more with 40 milligram in pulses like this. The study was again stopped early, and you can see that basically 40 milligrams once weekly became kind of the norm. On the right here, you can see what's called a Kaplan-Meier curve. In brief, on the x-axis on the right here is time, and the y-axis is survival, and this is a percentage. So for example, here in the group, this is basically, these are death due to death due to toxicities, overall survival. So at the 2-year mark here, for example, 90% of the patients in the Dex 40 milligrams once per week group were still alive, versus in the group that got these high Dex pulses, only about 65, 70% of them were alive at 2 years. Again, with myeloma, though, the problem was all the side effects that come with dexamethasone, so blood clots, heart issues, and so forth. So I'd like to believe that it's that simple and that dexamethasone dosing has gone down consistently over time. Unfortunately, it's not that simple. This is a slide I always put up as kind of a cautionary tale to my colleagues in the field to remind us we really need to do better by our patients. So these are just 2 studies over time. Again, I'm cherry picking studies here to illustrate a point, but you can see here basically that, in this study, 2008 to 2012, the SWOG SO777 study, looking at these 2 regimens, Dex was dosed on maybe 14% of all days patient got some dexamethasone, or 19% of all days. In the Perseus study that was more modern, it was a European study, again, not an American study, the Europeans used dexamethasone pulses, even in the modern era. So what's happening here, if you look at these studies, and these are big studies that led to the approval of VRD and then DARA VRD, it feels like one of these McDonald's, supersize me things where ironically dexamethasone is going up with time and not down. This is a problem, and this is what I'm trying to work with in my research to be able to fix. To be clear, I don't want to make it seem like dexamethasone is always the wrong answer. There are several scenarios, as I'll talk to here and there, where dexamethasone does have some benefits. In older studies, for example, here for doublet therapies, so if you're only using doublets, so 2 drugs, typically in the relapse setting, dexamethasone does seem to have some form of benefit. This, for example, was an old study here of pomalidomide or Pomalyst, so Pomalyst plus Dex versus Pomalyst alone, and you can see here the median progression-free survival. So that means how long is a patient on average alive and in remission was 4.2 months if you added the Dex versus 2.7 months if you didn't have the Dex. You could argue that's terrible, right? That's like basically a month and a half, 6 weeks of benefit, but both arms did terribly, and I would agree with that. In the modern era, we would not give someone just Pom Dex. We would give something else on top of it. Similarly here, in this old study of isatuximab, which is Sarclisa, that is an IV drug that blocks CD38, similar to Darzalex Faspro or Dara, that many of you may be familiar with, they found that if you gave just to ISA by itself, the median progression-free survival, so again, how long was the average patient alive and in remission for, was 4.9 months, versus if you added the Dex, 10.2 months. Again, I would not consider this to be an appropriate regimen in the modern era because we don't give doublets. We give more regimens. We give 3 drugs, sometimes even 4 drugs to make things work. But in those settings, dexamethasone does have some benefit in terms of efficacy. However, things can go wrong in terms of chronic dexamethasone. So this is an example. I saw Cindy mention the HealthTree Cure Hub before. So this is an example where I am very grateful to patients who, signed up for the HealthTree Cure Hub and donated their data or allowed for their medical records to be linked back and forth. This is an example of the research that we've been able to do with it. So I thank you for that and for your partnership on this. And so this was work that we led that was published in the American Journal of Hematology earlier this year. And that's actually a pretty high impact journal for the field. You can see, for example, there's Jenny Alstrom, there's Jay Hydron, some of you may have met him, did a lot of research efforts here. There's me. The association between dexamethasone exposure and visually significant cataracts and multiple myeloma. And so what we did was, we asked patients to tell us about their self-reported risk of cataracts, not cataracts that an eye doctor picks up in an eye exam, but cataracts the patient remembers. And so you can see here, basically, this is another Kaplan-Meier curve going in the reverse direction here. It's kind of hard to read the full text, but the idea is that dexamethasone tends to go, the risk of cataracts tends to go up with time. The longer you're in dexamethasone, the higher risk of cataracts. You can see it go up, up, up like this. And by, I think I can't even read it myself, several years into it, almost 100% of patients will report cataracts. Here, this was more interesting. We went back and looked. There were about, I think, 50 something patients who kindly allowed us to link their medical records back to their dexamethasone dosing. So we could go back and look very granularly and calculate lifetime doses of dexamethasone. So for as long as that patient's been on myeloma treatment, how many milligrams of dexamethasone have they received? You can see here it goes into the thousands, right? People are getting a lot of dexamethasone. Many of you have for month after month, year after year. And this on the y-axis here is cataract severity. So it was a 1 to 5 scale of basically, again, not just are there cataracts versus not, but how burdensome are these cataracts for you? How bothersome are you? Do they affect you? Do you notice them? Do they prevent you from being able to drive? Number 4 on the scale was, preventing you from driving. Number 5 was they had to stop treatment because of cataracts. And you can see here, it's slow but subtle. There is a curve kind of points upward here, that as people are more dexamethasone, the risk of visually significant cataract starts to go up. A follow-up project. This is unpublished data. So for those of you who are on social media, please don't tweet or put this particular slide. It'll be presented and published soon. The rebuttal that we offered to ourselves and the journal when we published this had the same question. Well, maybe it's just a function of age, right? If someone's older, they are by definition going to be on dexamethasone for longer, right? The longer you live with myeloma, historically, the longer you'll be on dexamethasone. And we know for a fact that cataracts do go up as people get older. That's a fact. And so could that just have been that as people get older, living with myeloma, they have more dex and they have a higher risk of cataracts, and the two are not related. So we actually did some very savvy statistical modeling. I can take no credit for this, but the HealthTree team can. Again, using data that many of you kindly participated in a survey about dexamethasone, looking at your risk of various side effects and what dose of dexamethasone you were on. And here, basically, you can see that for patients who are on high dose Dex, over 20 milligrams weekly, versus low dose Dex, meaning less than 12 milligrams or no dexamethasone whatsoever, the risk of cataract does go up independently of age. So if you look here, no matter what age, whether you're 40 years old, 60 years old, 80 years old or more, the more dexamethasone you're on, the higher risk of cataracts regardless. So that's one thing that we've talked about at length, and I'm happy to talk about that more in terms of eye health among patients living with myeloma. Other things can go wrong with dexamethasone as well. Unfortunately, this hasn't been very well studied, and this is one of my research areas, really looking into this in more detail. Myself and maybe 5 collaborators across the world are really, this is kind of our passion area. But a few other people have looked into us. This was a study done led by one of my colleagues, Dr. Corday at Memorial Sloan Kettering in New York. And here they use a wearable device to track patients' sleep while they're on dexamethasone. And you can see here, basically, it's kind of hard to read, but basically this is minutes of sleep in a 24-hour period. Orange are the Dex days, green are the non-Dex days. And basically, these are individual patients here paired back to back to back. And you can see, for example, like this patient, this patient, this patient, this patient for sure, where the amount of sleep they get on their Dex days is way worse than the amount of sleep they get on their non-Dex days, like in a 24-hour period, including naps and so forth. Again, for those of you who are listening to this, that may be obvious. Many of you are living this. I think it was telling to see it so scientifically. And indeed, in talking to Dr. Corday, she mentioned that some patients don't even realize it. So even the patients who feel like they are sleeping well on their Dex nights, they're not. If you actually look at their sleep monitor, right, and see how restful their sleep is and how many minutes they're actually in deep sleep, it's lower. So we know that, and that's the known entity. This on the right is not particularly about dexamethasone, but it's just an annoyance that I know many of you experience week after week. This is a study looking at what are risk factors for patients not being able to take their lenalidomide, their Revlimid, consistently. Right, lenalidomide is Revlimid. Many of you are on it or have been on it. That is a workhorse myeloma treatment. It's a pill, but as many of you know, people are on many pills, and so the more pills you're on, it's easy to forget some of them. And so they look basically here: what are risk factors for patients not remembering to take Revlimid as consistently as they should? And you can see, for example, some of these, cognitive impairment patients who have some early dementia may be more likely to forget to take the Revlimid on a given day. Depression is a significant. Actually, these aren't even significant, but it was looked at as a potential risk factor. Polypharmacy, which means more than one medication, was a very strong predictor of forgetting to take Revlimid. So the more medications that you're on, the more likely it is you may just forget to take the one that's actually important, the Revlimid. And if we've argued, as I just made the case, that dexamethasone is not that important, you could argue that dexamethasone may actually be hindering your ability to remember to take the pill that actually matters. So that's all nice and good, but can we look at this more consistently? And so here, this was a very elegant study led by the Italians, Dr. La Rocca. She was the first author of this, published a couple of years ago in Blood. This was a randomized trial. So randomized trials are the gold standard. They are very difficult to run, obviously, and it's asking a lot of patients. So you really have to convince the patient that both arms are reasonable for them, and both arms are ethical for them to be on, and then trying to figure out what the correct answer is in between them. What they did was these are older, by European standards, so over 65, a little bit less fit. So intermediate fit is what they would say, and we can talk about that. So maybe not quite as functional as they were 5, 10 years ago. And everyone got RevDex. So again, this is a doublet, not what we would give in the US today. RevDex, so RD, so Rev is lenalidomide or Revlimid 25 milligrams, Dex here 20 milligrams weekly. They did two things here. So half the patients went on to just Revlimid maintenance. So the Revlimid got dropped to 10 milligrams instead of 25 after 9 months. And the dexamethasone was dropped. And the other arm was randomized to just stay on this indefinitely. So the Revlimid stayed at 25 milligrams for the long haul, and the dexamethasone also stayed. So again, these half of patients, nothing changed after 9 months. These half of patients, after 9 months, the dex stopped and the Revlimid dose was lowered. Here were the events they looked at. PD is progressive disease, so the myeloma coming back up, death, having to stop the Revlimid, or any of these toxicities, what we call AEs, adverse events in the field. So a couple of things happened. So in terms of looking at all those events, you did see that the group that had the Dex-sparing arm did better. So again, here, this curve is looking at months here. You've seen many of the Kaplan-Meier curves. Here on this axis is not just how long are they alive and in remission, it's how long are they alive and in remission and on the Revlimid and not having any of these very high-grade toxicities or very serious toxicities or side effects. And you can see here that this was significant, that the group that had the Dex stopped after 9 months had much better event-free survival than the group that stayed on full-month dexamethasone. It wasn't so much a function of PFS, of progression-free survival, how long they were alive and in remission for. Again, mainly driven by toxicities, that the patients who stayed on the full-dose Dex had toxicities and therefore had to stop treatment or hold treatment and therefore had these events happen. This, I thought, it was really illustrative and very important because it illustrates the point I brought up on the previous 2 slides ago, that here, the median cumulative len dose, so how much Revlimid did patients total get altogether, was higher in the group that stopped the Dex versus the group that didn't stop the Dex, 5,800 milligrams, 5,400 milligrams. Again, this is lifetime, right? That's a very high amount of dexamethasone, but over the course of being on the study. This was despite the fact, if you recall correctly, that in the group that stopped the dexamethasone, after 9 months, you cut the Revlimid from 25 down to 10 milligrams. So even despite cutting the Revlimid dose by over half, If you cut the Dex, people don't have as many side effects. They're able to stay on the Revlimid for longer. They remember to take the Revlimid for longer. They do better for longer, and therefore they get more Revlimid into them. And again, if you would believe that Revlimid is a good myeloma drug, which I do believe, then this is very important. Here, overall survival was not quite statistically significant. Those of you who have a background or remember some of these stats know that a p-value of 0.05 is considered significance. This was not quite, but just throwing it out there, at the 3-year mark, patients who had the Dex stopped, 74% of them were still alive. This is overall survival. OS is overall survival. 74% of them were still alive, versus the groups that stayed on the continuous high dose, the continuous Revlimid and Dex, only 63% of them were alive at the 3-year mark. So that's the same question comes up again. Is the dexamethasone truly helping or is it starting to harm people? And so we wanted to look at this more robustly in a more modern era here of patients, primarily who are getting triplets and quadruplets. So what we did, and this is work that I led, which was part of the reason I was invited to talk to about this, was published last month in Blood, one of the biggest journals in hematology. We looked at 2 large studies of myeloma, the SO777 study and the S1211 study. Both were groups led by academic investigators. You may remember I mentioned the SO777 study earlier when it looked at VRD versus RD. So both arms in that arm got Revlimid Dex RD, but one group also got Velcade or bortezomib on top of it. And so that was the SO777 study. There was also the S1211 study. That was a study of adding on a drug called elotuzumab or amplicity, and that was shown not to improve outcomes in the setting of high-risk multiple myeloma. Here's how dexamethasone was dosed, basically. So I just gave a sample schematic here. This arm, so a quarter of the patients here got dexamethasone 40 milligrams once per week forever. Many more of them got this kind of an approach here where the dex was split, so 20 milligrams twice per week here and 1 week off in 3-week cycles. In both protocols, again, many of you who have done clinical trials know that unfortunately protocols tend to be very strict because of who makes the protocols, or the FDA often requires it to be very strict about who is allowed to stop the drug or go down on the drug. And so here you can see this is what they did. They required patients to have grade 3 toxicities or higher. Again, grade 1 is mild toxicities, grade 2 is moderate, grade 3 often requires hospitalization, grade 4 is life-threatening, grade 5 is death. And so these are pretty high-grade toxicities. Only for a high-grade toxicity, basically requiring hospitalization, were you allowed to lower the dexamethasone, for example, stopping or going down to 12 milligrams instead of 20, or 10 instead of 20, etc. And so we looked at these patients, everyone who completed induction in these. Again, these are clinical trial participants. So these are patients who are very motivated, went to an academic center, did a clinical trial, on a clinical trial, often tend to be healthier. We broke patients into 2 groups. FD Dex was full dose Dex, those who stayed on that full dosing schema from the slide I just mentioned. LD Dex are patients where the Dex was lowered or stopped because, again, of toxicities during the 6 months of induction. The 2 groups are pretty balanced in terms of things you might think might make a difference in terms of age, PS is performance status, ISS stage, a stage of myeloma from 1 to 3, in terms of the baseline M spike, even CRP. Some of you may have heard of this before who've gotten CAR T. CRP is a measure of inflammation. They're pretty similar in those arms. This was one of our big conclusions in this Blood paper that just got published. Even on clinical trials, less than a third of patients were able to maintain full dose Dex. If dexamethasone was a new drug, for example, if it was a brand new drug being investigated, the FDA would never allow this to be continued at this dosing, because that's absurd, right? That over 2/3 of patients could not tolerate the dexamethasone at the dose that they were prescribed and had to go down on it. We would require the dex to be lowered. However, because dex is an old drug, it kind of just slips through the cracks and continues at this rate. So I thought that was very compelling. And more importantly here, looking at these, PFS and OS. Again, PFS is progression-free survival. How long are patients alive and disease-free for on the left? Overall survival on the right is how long are patients alive for. No difference whatsoever. Those curves are identical basically between the group that had full dose Dex versus low dose Dex. We did what's called multivariate analysis. So those are kind of complicated ways for us to kind of assess what is really making a difference towards PFS. Again, how long are people in remission and alive for? And OS, which are how long are they alive for? Dexamethasone did not matter. We even looked at just the patients who got VRD. So forget the patients who got only RD, the patients who got VRD or ELO VRD, same principle. Whether they got Dex full dose, 40 to 60 milligrams per month, so to speak, or per week on average, versus lower did not make a difference in terms of their overall efficacy of treatment. So what's next? That's all well and good. I think what this has taught me, the slide before this, I'll go back for two slides here. This is important because, those of you on social media know that, there is a diversity of opinions in myeloma, and there are people out there who say that, oh, well, we should maintain full dexamethasone until we do another randomized trial comparing Dex 40 milligrams once a week versus Dex 20 milligrams once a week. Because if we don't have a randomized trial, we'll never know. I would say I appreciate that pie in the sky attitude, but that's not practical. That's not fair to our patients, nor is it practical. Because again, if even in a clinical trial, over two-thirds of patients cannot maintain 40 milligrams weekly of Dex, and we know that it causes toxicities, it's not ethical to run a study like that. We don't need to run a study like that because we already have our answer. We know that dexamethasone lower than 40 milligrams is the way to go. So where do we go from here? I don't think we need a randomized study. I think we should start doing it. That's our goal here. And so this is a study that we are leading here at Fred Hutch up in Seattle, a phase 2 study, and there'll be many more studies like this coming. There's a similar study like this happening in Europe already that just started. We're calling it the Eye Clear Dex study. So isatuximab, which is Arclisa, carfilzomib is Kyprolis, lenalidomide is Revlimid, and reduced exposure dexamethasone, so reduced Dex. And basically, this is just an example of the study, what we're doing here, not just in real life, but in study. We're giving patients this particular drug here, the combo called ISA-K-RD. After the first cycle, the default plan is to lower the Dex, to omit it unless you need it for symptom control. Again, to be very clear, I'm not saying that we should forbid Dex altogether. The cataract research that we've done with the help of patients who did HealthTree shows that really lower doses matter. If you can stop it entirely, great. But if you need a lower dose of it, totally fine, right? Because I should clarify, dexamethasone can sometimes help with bone pain. Dexamethasone can sometimes help prevent nausea from the Kyprolis. Dexamethasone can sometimes help prevent infusion reactions. So many of you, when you're starting a new regimen, even if you hate the dexamethasone, they'll ask you to take it for the first cycle or two, just to make sure that the new drug is well tolerated, doesn't cause any allergic or infusion reactions, etc. But again, the default should not be to continue full dose Dex unless the patient has side effects. The default really should be lower the Dex or stop the Dex unless there's a reason to continue it. And so we're trying to just make that subtle switch in the field bit by bit with a study like this, and hopefully the inertia will build thereafter. This study, whether someone's on transplant or not, they can go on to it, which I think is a really important step. Which again, it should be enrolling hopefully very soon, in a couple of months. And so the final point I'll bring up here, what should you do if the dexamethasone is needed or is helping, or your doctor strongly feel that you should be on it? These are the tips I give to all of my patients. So again, dexamethasone can cause sleep issues. So I say try to maximize sleep hygiene. If for some patients, topical CBD, if that's allowable or advisable for you, that sometimes helps. Benadryl sometimes helps, etc. Some people, the Dex causes stomach acid issues. So on the left there, take Dex with meals, maybe add antacids if needed, for example, like Tums, something along those lines. Bottom left, some patients with Dex really causes leg swelling, particularly at night. So if that's a problem for you, you need to stay on the Dex. Again, ask your doctor if you can go down on the Dex, but if you can't, try to raise your legs at night. Sometimes patients are on water pills, so which like Lasix to help pee the dexamethasone out. On the bottom right, dexamethasone absolutely can cause muscle weakness and bone weakness over time. Many of you know that and have lived through that. So I say exercise very regularly. I think is an important point of being, living with myeloma while dexamethasone. In the middle there is pointing to that patient's heart. So make a regular PCP appointment for your bone health, diabetes screening, etc. We know dexamethasone can cause bone health issues. We know dexamethasone is one of our research areas, can cause higher blood sugars. So being aware of that is important. And then again, as many of you have heard, thanks to HealthTree research, we know that dexamethasone can cause eye issues, like cataracts in particular. So get your eyes checked regularly and get new glasses as needed. Don't assume that it's the myeloma making your eyes worse. Assume that it may be the dexamethasone, for example. The big piece of advice I give to everyone to join a patient support group, right? So many of you listening to this probably are part of a patient support group through HealthTree, or maybe you're coaches or something along those lines. I think that's helpful because I feel like this is just the tips that my patients have taught me. I'm sure there are many other tips that others of you have experienced to how to live with dexamethasone. And so I think a patient support group, hearing from other patients, is the best way to do it. And so my last slide here, and then I'll leave questions. It'll leave plenty of time for questions. So again, going back to my first point here, Dex 40 milligrams weekly was the hero of myeloma treatment. Now I think appropriately long-term Dex is the villain of myeloma treatment. And if we as physicians don't know what side effects you're having, we can't help. And so what I would say is, ask your myeloma doctor if down with Dex is right for you. That's the hashtag that we use on social media as a field to kind of push to say not abolish dexamethasone, just down with Dex. Dial it down to find a dose that works for your patient. And so, if this is something that you're having side effects with, ask your doctor. More likely than not, you may find that they're willing to work with you to lower the Dex or stop the Dex accordingly. And with that, I will stop. This is one of my favorite quotes from a book that I would encourage you all to read by Siddhartha Mukherjee, who's himself a cancer doctor, The Emperor of All Maladies, a biography of cancer. It's a very nice quote here about someone living with myeloma, and this is what I hope for all of my patients. With that, I'll stop, and I'm happy to take questions. Thank you again for listening.
Awesome. Thank you so much, Dr. Banerjee. I appreciated the nod to Jenny's feelings and experience with dexamethasone and all of the great information and research you brought our way. So thank you.
Mhm.
Um, so we do have some questions, but I just want to encourage everybody, of course, now is the time for the discussion part of our webinar. If you have any questions about today's topic, go ahead and drop those in the Q&A. And we will just jump right in.
Great.
Go. Perfect. So our first question is, how important is Dex in a DRD regimen for newly diagnosed, 71 years old? And then how long or what kind of advice do you have for a patient in considering that and speaking with their doctor?
Absolutely so. So it's an excellent question. So in brief, we don't know. Technically, is the short answer. I don't have a randomized trial of this. There actually is a randomized trial, ironically, ongoing of exactly that question. The SWOG 2209 study is looking at three arms, actually. Patients who are not going to transplant, either getting Dara Rev Dex, like you alluded to, for the long haul until toxicity or progression, myeloma coming back. Dara Rev Dex, but stopping the Dex after 9 months. So again, that 9 month study I mentioned, that was with Rev Dex, but now doing with Dara Rev Dex and going to just Revlimid, or VRD Lite, which is another regimen not typically used in the US quite as much anymore. And so that will help answer that question. I would say that study will take years to read out. In the absence of that, I typically say 6 to 9 months is what I recommend of kind of full dose treatment, because that kind of you get the most bang for your buck there. The dexamethasone I still routinely try to lower or drop during that time. But after 6 to 9 months, especially 9 months, generally for almost all of my patients, I offer them to either go down to just Dara or just Revlimid, or if they haven't quite achieved a good response, Dara plus Revlimid, but drop the dexamethasone. Because I would argue that at least based on the Rev Dex versus Dex, that Italian study I alluded to, after 9 months, like we have at least randomized data from a doublet showing that dexamethasone does not add benefit, only add toxicities. And so I would argue that if we know the dex is going to cause eye issues, we don't know that it's going to actually help, I would favor stopping it. In case your doctor tells you that, oh, you're not allowed to help with dexamethasone because it's needed as a pre-medication before the DARA, before the DARS look, that is not true. I always joke to patients giving these talks that if that happens, tell your doctor to talk to one of us, to talk to a myeloma specialist, and we're happy to educate them on that. That is not the case. In general, the risk of an allergic reaction to DARA or ESA or any of the regimens is basically infinitesimally small after the first month, especially after the first 2 months. So for all of my patients, to lower the quote unquote time toxicity of treatment, I drop all the pre-medications. No Benadryl, no Tylenol, no Dex, no nothing. Just the active ingredient, so to speak, the Dara injection, and roll with it. So I would say that that should not be a reason to stay on the treatment. To stay on the DARA, to stay on the DEX, I'm sorry. So I would say neither from an efficacy perspective nor from a safety perspective is it warranted. So I would favor stopping it. But you always can start it again later if needed, but I'd rather stop it just to prevent that risk of cataracts and all the side effects that come with DEX.
Perfect. And I know I've heard you say it before about having doctors consult with other physicians. What's the best way to approach that with your physician? And what would that look like?
I know it's an excellent question. And so, I would say, again, I am biased because I'm on this side of things. I would say that 99% of the community physicians I've worked with are very appreciative of that. They love the idea of being co-managed. So first, for a patient, what to expect. Honestly, like only half of my patients are actually patients whom I primarily follow. The other half are patients who are followed primarily in the community by a doctor who knows them, who like lives close to them. Most of my patients would rather not come to the big city unless they need to, and I'm totally fine with that. So I see them every 6 months exactly literally by this medium, by Zoom, by telehealth, and just check in with them. That's the best of both worlds because I can talk about dexamethasone, I can talk about CAR T, I can talk about MRD, all these new concepts in myeloma that are constantly emerging, I can talk about. Any big decision points about changing treatments, etc., I'm happy to weigh in on. But all the day-to-day stuff, patients are able to go with a doctor who knows them the best, who knows their community the best, who's much closer to them, etc. So I think most community doctors, community oncologists also appreciate that. And I'm very grateful for them because one, I cannot see everybody. Two, they know the community resources much better than I do. So, like for example, here in Washington State, I don't know this Spokane area that well, and the docs who live there do, and they know resources and so forth. And three, a lot of my patients, I have patients who have more than one issue going on, like they have myeloma, but also prostate cancer, or myeloma, but a history of breast cancer on Arimidex. And for those patients, I am 1,000% grateful for the community oncologist because I don't treat breast cancer, I don't treat prostate cancer, I know nothing about them. So it's much better to have someone there. So basically, with that in mind, I think it really is a win-win-win scenario. And I have yet to have a patient tell me that their primary oncologist was reluctant to refer them to an academic center. Most times, academic centers don't even need a referral per se because we can do it ourselves. And so all big centers will have a way where you can go on the website and be like, I let's request an appointment, and we can figure it out. Many of us have cross-state licenses. So, for example, I have patients in Idaho, Montana, Alaska, Hawaii. I have a California medical license too. I don't ask the patient to fly into Seattle to see me. I just see them at telehealth. It doesn't work for everyone. Unfortunately, there are a lot of cross-state issues, unfortunately, which have been a problem we're trying to fix as a field. But apart from that, I think in most cases, we're able to do a telehealth consultation no matter which academic center you're going to. So I would recommend that. And so how to go about it practically, I think just asking your doctor, be like, oh, I read about XYZ, or I heard about dexamethasone, or CAR T, or myeloma MRD test. I'd like to speak with an expert. What do you think? Most of them would be very happy to put that referral in. If they are not, or kind of like, oh, I don't know how to, you always can self-refer. Or, Cindy, if I can put back to you, I know that HealthTree has resources. HealthTree has a coaching program and has a website. And I think there are resources there where you can have HealthTree just kind of help coach you on what to say or what to do, or even guide you through putting that referral in.
Perfect. I love it. And thanks for the shout out back to
Mhm.
us as well. Um, and I love that idea of collaboration. I think that's wonderful. I'm grateful that we live in an age where it's so easy and so available. So that's great.
Absolutely so.
Perfect. So next question is, if I had cataract surgery this year and I started back on Dex, what are the chances that those cataracts will come back?
An excellent question. Ask me in 5 years, I'll know the answer to that question because we are researching it. Unfortunately, I don't necessarily know for sure quite yet. What I would say is I think it's a discussion to have with your eye doctor about that, but both your eye doctor and your myeloma doctor, because clearly there are some patients who have other risk factors, for diabetes can do it, advanced age can do it, and so forth. And depending on what kind of cataract surgery and where the cataracts were, that risk varies from patient to patient. That being said, I would say, especially for someone where you've had significant cataract requiring a surgery for them, you have more to lose if the cataracts come back. So I would say that in your case, I might push a little bit harder to say, well, show me why you want me to stay on the dexamethasone. Because it's possible to quantify that risk, but even if that risk is higher, because you've already had surgery for it, by definition, whatever risk factors you have for cataracts are a little bit more pronounced. And so I would suggest maybe erring again on the side of trying to stop the dex if you can and not raising it. Again, one dose of Dex here and there is fine. If someone gets CAR T therapy and needs dexamethasone for that, that's totally fine. If you need dexamethasone for a month, starting a new line of treatment, totally fine. It's just more, as the first question alluded to, once you achieve a response for the long haul, there really is zero benefit of the dexamethasone at that point. So I would favor, especially if you've had side effects from it, to lower the dose or to stop it entirely.
Perfect. Thank you. Next question is, can Dex cause liver issues?
It's a good question. Generally not at these doses, once a week dosing. Technically, dexamethasone daily for many days can sometimes cause issues because your liver metabolizes the steroids. I wouldn't expect it to. If that's happening, and maybe another medication like bortezomib, Velcade can do it. Amyloidosis can do it. And I think it's worth a discussion with your doctor. I wouldn't presume for dexamethasone itself to do it. Now, I haven't seen that where I've said it's just the dex doing that.
Perfect. Um, what about the Dex that seems to be added to some of the newer regimens, such as bispecifics, our second or third line therapies? Is it possible to ask to not include Dex in the treatment?
Yeah, it's a great, excellent question. That's a good point. So on a clinical trial, if you were who asked that question are on a clinical trial of a bispecifics in earlier lines with dexamethasone, is a little bit trickier, unfortunately. And trust me, I have raise hell with trial sponsors to say like you should drop the Dex for sure, and they're working on modifying the protocols to accommodate it. What I would say is for bispecific antibodies in particular, with the first cycle or two, dexamethasone is supremely important as a tool to mitigate the risk of CRS, cytokine release syndrome. And again, like for example, at Fred Hutch, we're operationalizing outpatient bispecific antibodies. So we're not even requiring people to go to the hospital anymore. We're doing an outpatient, but a key component of that is having the patient have dexamethasone at home. So if they have a fever, again, we can talk about CRS another time. CRS, basically, for those who don't know it, it's a form of inflammation, cytokine release syndrome, where for any immunotherapy, like CAR T or a bispecific, all of a sudden the T cells, the immune cells recognize this threat that they didn't see before. You get high levels of inflammation, and that can cause a fever, so that can be life-threatening. And so dexamethasone can lower that risk. And so to start with, we typically recommend it. If someone gets CRS, we often use dexamethasone. And I have had patients where they get local injection site reactions. So from the teclistamab, which is Tecvayli, or talquetamab, which is Talvey, or elranatamab, which is Arexvio, or these clinical trial bispecific antibodies, they get like a big rash where the injection went in. And so for those patients, I often do keep the Dex for a little bit longer, but even then I start to lower it because I would argue that it's not adding that much benefit. If you're asking why is the study so, why is it so slow to change the field? Again, part of it, honestly, is not just the drug companies. Part of it's the drug companies. They tend to be cautious. Part of it, unfortunately, I've had this happen where it's the FDA. The FDA is very conservative, like some of the most conservative drug approval people in the world, and they are very much like, oh, well, we will only approve this new drug if you take the exact old regimen that had dexamethasone and add one thing onto it, tweak one thing about it. And if you try to change more than one thing at once, the FDA said we won't allow that. We won't approve your drug anymore. And so it's kind of this, it's this weird impasse that we're in that I'm trying to do my research to fix. But that's part of it. Like if you're wondering, well, if you see all this research, why are the sponsors still requiring Dex on the trials? That's why. That's kind of my 5-year, 10-year project to kind of help just fix, get the drug companies and the FDA to talk to each other, get them to realize that dexamethasone is not the hero we think it is, and lowering it or stopping it. So it'll take some time to get there. But again, that's for clinical trials. If you're getting talquetamab or teclistamab, any bispecifics commercially, definitely very reasonable to stop the Dex. I routinely stop it. I routinely stop all the pre-medications unless there's a reason to continue them. For example, not CRS, but if they're having recurrent skin issues with each injection, that's a reason to continue it.
Perfect. So I've got a patient that has had sleep issues, of course, personality issues associated with their Dex dose, went from 40 down to 20, and trying to decide how to talk to their physician about even dropping down as low as 12. Is this something that would be reasonable?
Very reasonable. So a lot of my patients are on 12. So on that study, I alluded to the iClear Dex study what we're running. Anything 12 milligrams and under, no questions asked is fine. Like in my mind, that's not really like obviously no Dex is better, I would argue, but 12 Dex is very reasonable. Not for efficacy, to be clear, but in terms of safety. Because some people do get not safety as per se side effects, right? Some people do get allergic reactions or bone pain or night nausea. Dexamethasone is a good nausea med. So 12 milligrams, I think, is fine. I think it's very reasonable to ask for that. And again, that's 12 milligrams taken at home, like 3 of the 4 milligram tabs, not in clinic. I think most doctors will be fine with that. There are guidelines, there are dexamethasone papers that talk about that. If that's a problem, I will say that first thing we talked about seeking an academic second opinion is very reasonable. Honestly, half the time, that's all that I do. My job is after the consultation, I go back and tell the community doctor, you're doing 99% of things right, but drop the Dex, drop the Benadryl, drop the Tylenol. Honestly, more than not, that's the only thing that I can counsel a local doc because they're doing things excellently. It's just that point. Just because all I do is myeloma, I hear this, side effect very regularly, and I think it's worth it. Um, Anything else that will add there? If other things come up, if your doc is super nervous about it, I have had patients where I sometimes split the dose. So instead of 12 milligrams the day of, we do 8 the day of and 4 the day after. Sometimes that tends to help a little bit. Not so much for sleep. That's often for patients who feel like they need the Dex, but on the day after they stop the Dex, they have what's called a letdown effect, where they just sleep all day, where it's almost like they have this kick and then have a crash afterwards. Splitting in the 2 days sometimes can help with that. Again, I would much rather favor just going down on the dose and not trying to play around with it because, again, the Dex is not adding any efficacy benefit in terms of how well the treatment works. It's maybe helping with side effects, but it's causing a lot more side effects.
Perfect. I like that. I like that customized approach to
Mhm.
just listening to what is happening with the patients and then moving forward. So thank you.
Mhm.
Next question is, what about pre-meds for IVIG? Is that something used?
This is great. These are excellent. All of you are very well informed because you've lived through this.
Yes.
IVIG, again, I don't want to make it seem like I'm anti-Dex. IVIG, I would say, ask your doctor if you need the IVIG, is what I would say. That's a bigger question to have because some people are on it for long because they had a history of infections or immediately after CAR T, but you don't need it for forever after CAR T, just for as long as you're not making your own antibodies. So there may be a scenario we don't need IVIG as regularly. You can go to every 2 month or every 3 month dosing. IVIG, just for those of you who haven't heard of it, is intravenous immunoglobulin, is basically an antibody transfusion. So for patients who cannot make their own antibodies, which for many of our patients with myeloma, they can't because we're giving drugs that kill out all the good plasma cells, which make antibodies, as well as the bad plasma cells that are the myeloma cells. For those patients, IVIG can be helpful. We basically take plasma, so everyone in the area who's donated blood, some of them donate blood plasma as well. You take all the antibodies that they have recently made against whatever they have fought off against whatever viruses, colds, vaccines they've had in the area. You put them all together into one sterile bag and you give that to the patient. That's IVIG. Because every bag of IVIG is slightly different and contains different antibodies that can cause allergic reactions, because again, they're technically part of someone else's immune system, that's a scenario where I very rarely do I drop the Dex or the pre-meds for that. For myeloma treatments, yes, because they're synthetic drugs. Because IVIG is not a synthetic drug per se, I typically do recommend the pre-medications for it. I will say that one of my colleagues, Dr. Fonseca at Rafael Fonseca at the Mayo Clinic in Scottsdale, Arizona, he's really interested in looking into subcutaneous IV. So not IVIG, but SCIG. So subcutaneous immunoglobulin, that's IVIG, but in the form of an injection. There are patients out there with autoimmune conditions who get it as they self-inject the antibodies into themselves once a month. That might work because generally, if you give a drug as an injection, it's not getting into the body as quickly. And so the risk of a big allergic reaction is lower as compared to an IV drip going in. And so that might be the future. And with subcutaneous IG, I would not routinely require Dex and pre-medications for the long haul. But for IVIG, I typically do just because I have had patients get reactions to it. So that would be a scenario where I think, but that again, that should be once a month. So once a month, if you get dexamethasone 20 milligrams once a month, you're not the person I'm worried about, right? It's the one who's getting it once a week, and that's what I'm really trying to push back on.
Perfect.
That's a great question.
Yeah, we've got a lot of really, really good questions in
Hmm.
here, so I'm trying to kind of bundle them together so we get as many answers as possible. Um, got one, is 8 or 12 milligrams the average for relapse refractory, or
It depends. It really depends. I think every
yeah,
patient scenario is slightly different. I would say most of my patients, I stop the Dex after a couple of cycles. If frontline, absolutely, but also relapse refractory setting. So someone on Dara KD or ISA KD, I stop it. Cal PD, I stop it after a time because it's not adding that much benefit. 8 to 12 milligrams is fine. For Kyprolis, carfilzomib in particular, I do have some patients who it's a good drug, but it can sometimes cause nausea. And so for that particular drug, I have had some patients who stay on the Dex exactly as you said, 8 to 12 milligrams once a week, or typically for maintenance once every other week, because Kyprolis is moved to every other week. That's fine by me. Jose, if you need to be on the deck to prevent a reaction of some sort or treat a symptom of some sort, I think 8 to 12 milligrams once weekly is very fine. If you don't think you need it, and often the only way to find out is just try stopping and seeing what happens, I think it's reasonable to try. Again, if someone's on a clinical trial protocol or getting IVIG or a bispecific, your doctor may have different opinions about this, but I think in the absence of that, I think it's very reasonable to try.
perfect. I think let's just take one more here. This one says they've been taking Dex for about 3 months with response, and there's some apprehension around stopping dexamethasone altogether, worried about numbers going back up faster. Um, what kind of a conversation would you have with a patient around that?
Yeah, so I mean, honestly, I have that coming more with doctors who are nervous and not the patients. I would reassure them both that a couple things here. One, dexamethasone, we just don't study enough. Ironically, dexamethasone is one of the first drugs that myeloma cells learned to resist. No drug in myeloma works forever. And so typically, and many of you have had, or you'll hear scenarios like this where we say, oh, the Revlimid stopped working, so let's move on to Pomalyst. We don't keep trying to Revlimid again and again and again when we see that it's not working. The same principle applies for dexamethasone, except that we do use Dex again and again and again. And we're trying to change that and be like, oh, that's silly because clearly these myeloma cells are not going to respond to Dex 40 milligrams once a week. The other points I would say about it is in the era of all these modern treatments, particularly patients receiving like a triplet or a quadruplet with these newer drugs are way more potent and way more powerful than just the Dex is. And so I would argue these new drugs are carrying much more of the benefit there. And the third part of it is that obviously, even in the off chance that you are wrong, it's always and the number two start to come up after starting the Dex. Technically, if that works, you always could put the Dex back on at that juncture. But more significantly, and this principle applies to both Revlimid and dexamethasone, in general, when the myeloma decides to come back, it is not the dose of the drug that matters because at any dose, the cells become resistant. So there's a very elegant data presented from the Mayo Clinic, published earlier this year in Blood Cancer Journal, looking at the same question with Revlimid. Because I have patients who, for example, after transplant, we typically say start at 10 milligrams, try to go up to 15 milligrams, but if you have side effects, go down to 5 milligrams or 2.5 milligrams. People get nervous. They're like, hey, doc, like I hate Revlimid. It makes me itchy. I have a rash. But if you think I need 25 milligrams of Revlimid, I will do it. And I tell them clearly, you do not. It's much better to find a sustainable path that works for the long haul that doesn't cause side effects, because in that study they looked and they saw that for patients who are on 5 milligrams of Revlimid when the myeloma decided to come back versus 25, was there any difference in outcomes? No. So my point being is that if the myeloma is destined to become steroid refractory, meaning that it learns to resist the dexamethasone, whether you're on 40 milligrams or zero, probably is not going to make that big of a difference. And so I think it's reassuring. Obviously, again, yeah, I don't want to put someone in a position where they have to stop the deck. If you feel like it's helping, some people feel like it helps with their mood, helps with their pain, and then totally fine to continue. But even then, I might suggest going down on the dose. Again, just because for someone getting diagnosed today, I think you mentioned that this patient's been on Dex or Index for 3 months. For a modern triplet or quadruplet today in November 2024, the average patient likely will make it about 5+ years of mileage out of it. That's my goal, with or without transplant, right? In the Myasephius trial, they made it 5 years, a progression-free survival even without transplant. And so 5 years of Dex 40 milligrams once a week is a lot. And those are the patients who are at risk of cataracts and bone health and muscle weak breakdown, et cetera. And so those are the patients where I would say, look, like if all else is equal, at least try going down on the dose, because I would say 8, 12 milligrams once a week is much safer than 40 once a week.
Okay, thank you so much.
Mhm.
My last question is just around your upcoming enrolling trial. If somebody's interested in that, is that at Fred Hutch or is it at other centers? What's
Thank
the
you for
story there?
asking. That particular
Yeah.
trial is only at Fred Hutch. We have funding for it. If you are in the Washington area, we'd be happy, would love to have you enrolled on this study. It is for newly diagnosed patients, to be fair. So most of you, by definition, by watching this, probably have been diagnosed and have started treatment already, so it wouldn't quite apply for you. Other studies are happening with the same principle. So what I would say is, for example, at the University of Pennsylvania with bispecifics, there's a study of stopping the bispecifics, seeing what happens. So I would say ask your doctor about it. There are studies running. The SWOG S2209 study is looking at stopping the DEX after 9 months, right? There are studies looking at de-escalating treatment because unfortunately in myeloma, we've had too many studies of escalating treatment and not as many of backing down on things. And so talk to your doctor about it because you may find a different detailed study, but the similar theme of de-escalating treatment based on time or a response to someone achieves MRD negativity or so forth. We need patients for those trials because that's teaching us what is the best way to personalize the intensity of how treatment is given. And so this theme, not just down with Dex, but down with everything, once it's no longer adding a benefit. I joke in my talks that it's like I'm like Mary Kondo for the myeloma field. If it doesn't bring you joy, cast it out. If the drug is not bringing you any benefit, cast it out. There are many examples of that in myeloma. So I would talk to your doctor about it if you're interested. We would love your help because most centers have some version of a trial in this space.
Perfect. I love it. Also, if anybody's watching that wants more information about trials that we have available through HealthTree, jump on our website, look at our HealthTree Cure Hub, and we can assist you with those as well. So I think we hit our time with you, Dr. Banerjee. I know there's a few more questions. I am going to go through those and add some additional resources in our follow-up email. But of course, want to thank you, of course, for sharing your time and expertise with us today. I know I've learned a lot, and it's been really wonderful to hear from you.
Wonderful. Well, thank you all for your time, and thank you, and Cindy and the HealthTree team for this invitation. I'll see many of you when I see you. We'll go from there. Have a good afternoon, everyone.
Sounds good.
Yeah,
Thanks,
bye
Dr.
bye. Mhm.
Banerjee. Bye-bye. All right, and we'll go ahead and close out today's session. There we go. Um, so I wanted to highlight a new resource that was recently developed by HealthTree and reviewed by myeloma specialists. The guide is a bispecific antibody guide, and it simplifies the science behind bispecifics, cutting-edge therapy options, and it provides a clear overview of how bispecific T-cell engagers work, their potential benefits, and the latest advances in research with practical details on administration, side effects, and comparisons to traditional treatments. This guide empowers myeloma patients and their care partners to make informed decisions about their treatment journey. I'll email this out with our resources in the follow-up email. As you leave today's session, we'd appreciate you taking 2 to 3 minutes to fill out a brief survey about your experience. Let us know how we're doing, what we can do to improve, and specifically if there are any topics that you'd like covered. I'm always looking for suggestions. Here are just a few of our upcoming events. The end of November is looking pretty full. So next Tuesday, November 12th, we've got a physician that will be joining us to talk about evidence-based pain relief for multiple myeloma, integrating holistic approaches to manage cancer-related pain. Thursday, the 14th, our Southwest and Pacific Mountain regions will be having a meeting to talk about cure teams. This will be specifically for that group and will be at 11 p.m. Mountain Time. Be on the lookout for further information. If this is not for your region, there will be more meetings soon to talk about our cure teams in those regions. Monday, the 18th of November, we've got a great presentation on nutrition and the gut microbiome and exploring their role in multiple myeloma. This has been a hot topic and something that we wanted to bring more information to you about. So we have many more virtual and in-person events in the works, so stay tuned. The link to sign up for these and any other events will be available at the bottom of the screen, and I'll also send out that link in the follow-up email as well. I'd like to again thank our sponsors, without whom this would not be possible: Pfizer, Regeneron, Johnson & Johnson, Sanofi, Adaptive, and Genentech. I've got one other thing to mention before we go. We wanted to, of course, highlight the ability you have to participate in research through HealthTree Cure Hub. This one that we want to highlight right now is a 3-year bispecific antibody real-world experience study. So if you are currently on a bispecific and would be willing to offer up some information about your experience, it would be really helpful to help with treatment for future patients and help us get more information there. On the screen, I have the link to sign up for HealthTree Cure Hub, along with the email address of our amazing patient navigators who are available to help you create an account and sign up for the survey. I'll also send that in our follow-up email. Lastly, as always, I just want to say thank you so much for joining us today and for helping us build a strong blood cancer community. I've added my email to the site, and I really do appreciate all of you and love interacting with you. So please feel free to reach out, and hope to see you again at another one of our events. Thanks, everyone.